I'm talking about a little bit adding on to what Dr. Singh talked about in terms of how to implement a feedback program. And how, in our group, how we started this with hospital medicine physicians and have subsequently spread it out to other clinicians. So I'm going to use the same Slido thing, so keep your phones out. This is going to be a little bit of a word cloud. So what do you currently receive feedback on from your workplaces? What kind of things do you receive reports on, or do you receive via email, or even when people talk to you? We'll see if it works. One person's typing. Two people are typing. Email, okay. Any type of information? Anything about patients? Anything that you receive feedback on? Safety events, okay. Teaching. We'll wait for the last two things to come up. Readmissions, good. Yeah, so like metric-based performance, right? Teaching, things that we do, but no one really tells us how we're doing it being a doctor or about diagnosis. Like, how did me as Gopi do? I hear about cases in general about maybe an outcome where there were multiple clinicians involved. But when I want to know about how am I doing, I'm not really getting that information back. So it's really, this whole talk is about me. And this is really how I felt when I would leave clinical service. I had a patient back, a couple of years ago, old man, came in with influenza, went to the ICU, then was transferred to the general medicine floor, was slowly improving. He was just weak, debilitated from the influenza, was on a little bit of oxygen. Our main problems were we had to figure out whether he could have anticoagulation or not. He had a history of a brain aneurysm, but really he was just getting better from the flu. So I finished service, I'm a hospitalist, so I finished my week of service and handed him off to my colleague who came on, and then I came in, I took one day off, came back in, and the next day the patient was talking about a heparin drip for this patient, when we'd clearly decided this patient, the risk was too high with this brain aneurysm for him to receive anticoagulation, so we really needed to stop it. And my colleague said, this patient has a large PE. So I realized my initial instinct was, he's making a mistake, but really it was that I had missed the PE. So when I went back and reviewed the patient's record, they'd been a little bit more hypoxic, maybe gone from 1 liter to 2 liters to 3 liters since I was on, and I didn't really recognize it. Patient didn't complain of more dyspnea. He was coughing in general from his influenza. So I didn't make much of it, and I definitely overlooked his symptoms. So in this scenario, how often is this happening for us? When we take care of a patient, somebody else comes on to take care of them, they change a diagnosis, but there wasn't really that feedback mechanism of, my colleague that took over for me was actually a very good friend of mine, ended up being a co-investigator on the study, and he didn't feel comfortable giving me that feedback, or it didn't even cross his mind that I'd want to know. So, I really wanted to know, how often is this happening? We talk about clinical reasoning a lot and errors a lot. I think errors feels like a harsh word, but I think it's one we have to get used to. But really, deviations in clinical reasoning is kind of what get you there. Whether, we talked about this earlier, whether it's the input of either what did you glean from their record? How was your physical exam? How was your communication skills with the patient to find out the correct information? But what kind of led you astray, that the diagnosis went wrong? Previous studies regarding interventions to improve diagnosis haven't really been the most beneficial, just because the number of errors are low in general. So it's hard to say you statistically significantly improve something that's already low to begin with, but there have been improvements. Errors are not recognized. So like in my case, if I didn't come back in, if I wasn't the medical director of that unit and didn't come back in to run rounds, I never would have known that I missed this diagnosis. And there wasn't really anything built in to give me that feedback. And then really the diagnosis is important, but really how I got there was important. It wasn't just that I missed the PE, it was what were the findings along the way that I didn't see. I didn't see the hypoxia. Was there a way that I should have been prompted? I didn't really notice that his symptoms were any worse. And am I questioning him wrong? Was I not examining appropriately? We talked about feedback, and we all think feedback is important. And I love this cartoon because, he's saying, who wants to give me feedback? And then he's holding a sign that says, I will crush you. I think as clinicians, diagnosis and our clinical care feels very personal. And although I want to know in theory, I don't always want to know in practice, because I'd rather just assume that I'm right. And I think this is a hard one to get over, but I think in general, the more we normalize feedback, more people feel more comfortable with it. feedback has been shown to really improve performance, mostly in learners. The studies have been done on this has really been in learners. And I think, I don't know, for all of you that work with medical students or residents, they seek feedback all the time. They want to know, how am I doing? Partially because they know I'm going to fill out an evaluation, but also just in general, they want to know how can I improve? And so in learners, we've seen this, but I feel like once you graduate and become a faculty, they're kind of just like, you've figured it out, right? You're fine. And there's really no feedback mechanism from that. And I don't receive very much feedback at all regarding diagnosis. When I would answer that question about what things I receive feedback on, usually it's like the food, the wait times in the ER, how cold it is in the hospital. And those are the surveys that I hear back from patients saying, what are the things that we could improve on? Not really like how I was doing with diagnosis. And kind of reasons that we don't really see, some of the reasons that we don't really get as much feedback is, I think part of it's silos. We work in these silos where we keep patients kind of to our team, and if I consult the gastroenterology team to come see a patient, they talk amongst their team, and then they just give me their answer with a bow on top. But there's very little discussion between us. Similarly, patients transfer back and forth. So if I send a patient to the ICU, it's an ICU team, and then they come out of the ICU and they're back on my team. There's not as much coordination between those teams, especially in the spirit of efficiency. We just kind of rely on what's in the notes, but there's not as much discussion. Similarly to what I said before, the diagnostic process isn't linear. So there's a lot of paths to get to the same diagnosis. And if someone comes in with dyspnea, is it wrong for me to start antibiotics until I know that it was really heart failure? You know, if I talk to my pharmacy friends and my antibiotic stewardship friends, they say yes, but what's my bigger source of harm here? That I missed a pneumonia or I was a little delayed on giving some Lasix? The last, concept is really the concept of situativity. And that's really a concept that says that environment and kind of creates the perfect storm for your reasoning. So when saying that only people that are really in that environment can understand what variables led to making that diagnosis, or that what led to that reasoning. And I think that's the hardest one to get to, is really a lot of the studies that have been done about diagnostic errors have usually been looking at cases based on readmissions, or based on mortalities, or based on malpractice claims. And that's a very skewed sample, because we know something kind of went wrong in those cases. But also in those, there's very few people that were involved in those cases kind of saying, maybe we should review this case, or saying, I saw this same patient in the same environment, and I made a different diagnosis. And that's kind of what we were looking at, is how to do that. In terms of current feedback mechanisms, there are some, incident reporting systems. I don't know about you guys, but at my site, it's 16 forced clicks to do an incident report, and then there's 12 optional clicks. I don't know who fills out the optional clicks. I definitely don't. But that's a lot of time and effort to report. I would love to report more errors or report more diagnostic kind of changes or issues, but that's a lot of time. And for a clinician that already is tired of clicks and the EHR is not my friend, that's a lot to ask. I'm not, completely against peer review. I think peer review has its place, especially the more modernized peer reviews where they've made it more about learning and systems learning. But previously they've been fairly punitive, and depends on kind of your system, on how punitive it is, in saying that you're attributing the outcome of this patient to one specific clinician, which isn't the most useful, nor is it an opportunity for growth. You're kind of blaming one person for a system that failed them. M&M conferences, I just don't feel like they're the most psychologically safe, depending on where you work, or your kind of how it goes, that you're really like dissecting a case really retrospectively and saying, here are all the things that went wrong, when again, those people weren't really there in the process of that case. And then mortality reviews are the most specific outcome that you have, and it definitely a skewed sample of cases to look through. So really, getting back to me, again, this talk is about me. I wanted to see feedback related to clinical care, and then feedback from somebody involved that actually also saw that patient. So I had to go to my colleagues to say, if I want you to answer questions about these things, what do you want to know about? And they said they wanted to give feedback on notes, on handoff, and communication, because those are the things that kind of made the biggest impact for them. If you pick up service from somebody whose notes are very unorganized, your first day is very hard. So they wanted to give feedback and get feedback in those senses. So we created a project where we really wanted to see how many diagnostic changes do we see from one clinician to another. How many of those diagnostic changes are errors? We know that diagnoses can change, and sometimes it's a test comes back and makes a diagnosis, and that doesn't mean that it's an error. Or the patient actually gets worse, and then the condition evolves. And then also, are there trends in these types of errors? Are there specific things that our group was missing and we were routinely making errors on? So this might be kind of hard to see, but the way it kind of works is, let's say Dr. Singh is a hospitalist with me. So if I finish service and handed over my patients to Dr. Singh, he would receive a survey during his week to say, on these random patients, 2 patients, did you change any diagnoses? And if he said yes, then it asked him, what did he change it from and what did he change it to? And that was all he's really asked. And he was also asked about feedback on notes and communication, but it was a pretty short survey, so it was a very short time constraint on people that were on service. If he says he changed the diagnosis, then that case was then sent to a team of chart reviewers that reviewed the case using his revised Safer DX that he showed, and I'll show it again, to ask whether the change was due to an error or not. And then we compiled feedback reports for each clinician to say, here are your patients for the couple of months. You've had 3 patients evaluated. You had 1 diagnostic change. Here's the error, and I'll show you the feedback report. And then our leadership really received the trends to say, we're making errors in these areas. Maybe we could focus education for our group on those areas. So this is the revised Safer DX. We kind of turned it into a little bit of a Likert scale. And you don't have to read you the questions, but really asking these questions about, was there a differential diagnosis? Were there any labs that were missed or any red flag findings? And then we included this, area to describe the error. And really this is for the chart reviewers to look through the case and describe their reasoning. When they were reviewing a case, was there an error or wasn't there? And really this synopsis is what was actually provided back to their colleagues for feedback. So we started surveys in 2019. I will point first to the asterisks that's there because we took a pause for COVID because we didn't want to add survey burden to people that were already working very hard in 2020. We had 641 surveys with a 97% response rate. I think the survey was short and we made it easy to do on your phone. So I think people were able to respond pretty well, and I'm very happy with that response rate. We had like 1,011 patients that were evaluated and a diagnostic change rate with around 18%. When they say, if you want to take a poll of the crowd, what do you think the diagnostic error rate was? Our Slido friend. 15, 20, 30, 43, okay. All over, all right. Another 15. All right, it's actually lower, it was 5.8%. And you have to also recognize that these errors were, because they were coming from one clinician to another, they were early in the day, there wasn't a lot of harm with these cases because it was ideally a diagnosis that was caught, right? If Hardeep changed one of my diagnoses on my patients, he picked up the patient and changed the diagnosis, so it wasn't like a long time had gone on. The highest were cardiology and infectious disease, which kind of goes along with what the slide that he had shown of cardiology, including VTE, which I felt vindicated, that VTE was a common diagnosis, but along with infections that were missed on patients. And our top were heart failure, pneumonia, and VTE in terms of the conditions that people were missing the most. So when we talk about feedback, I would say our priorities were 1, 2, and 3, psychological safety, right? This has to be done in a safe way for people to feel like they learned, but they weren't being talked down to, but also that they felt it was constructive. So what we did is we created feedback reports, which I'll show you, and we actually emailed them to the clinician and said, here's this report, here are a couple of available times, let me know when you want to sit down to meet to discuss them. And so then they would get the report, they could review the case, review kind of the findings and the synopsis, and then they could come with questions ready to discuss. So they weren't really, given the information all at once, they had time to really process it. And then we told them we want questions, and we also want your feedback on how is this process going? Is there anything that we could do to improve this? So this is kind of one of the feedback reports. This is, they had 3 surveys, they had 5 patients reviewed, 2 diagnostic changes. 1 patient had a diagnosis of a mass that was changed to sarcoma, but that was because of biopsy results, so it's more diagnostic refinement, not an error. The second one was an error, was a patient with chronic systolic heart failure who came in for chest pain, abdominal pain, AKI, was on Lasix for a couple of days without improvement and had new hypotension. The subsequent attending came on service and recognized the signs of hypoperfusion and stopped the Lasix, and the patient was sent to the CCU for dobutamine support. So that felt like that was an error. They also received feedback on the things they wanted, so the handoff, the communication, and the quality. So the purple is their score compared to the average in the division. So really looking for, what have we learned thus far is like trends and vitals and labs are important and easily missed. So not just with my case, but in general, we were seeing that people were not recognizing when someone was becoming a little bit more hypotensive, or they were having, fevers. I feel like it's a good job. It kind of prompts you when someone has a fever, but the EHR was not really made to kind of show like these random fluctuations in little bits of labs. Volume status and perfusion was hard for our clinicians, especially in our heart failure patients. So could we use things like POCUS or other technologies or other ways to kind of improve our assessment of volume status? And then, as Dr. Singh also pointed out, acknowledging our cognitive bias. So how much anchoring was there? How much of what we trace back to what that original clinician said was what was said in the ER, and that's why they made that diagnosis, of recognizing where are we making those errors. I think, or the impact on clinicians is kind of exactly what Dr. Singh was talking about. So proactive feedback plans. The goal for this is really to improve the culture of feedback along with seeing the rates of diagnostic errors. And what we found was that once the study had started, people actually said, you're going to fill out a survey on me anyway, so can we just touch base on Wednesday and just let me know how my patients are doing? And people were more open to feedback because they knew they were going to receive it anyway, but they also knew that it was coming from a safe place. And they felt less anxious. People felt like they were getting in the records less often. They didn't feel like they had to stalk all their patients after they finished service to see what happened because they had an open avenue to receive that feedback. So our biggest takeaways are errors in clinical reasoning and diagnosis are common, but hospitalists, and I'll say all clinicians thus far, are open to and appreciate feedback. So learning about errors are an opportunity for improvement. I think there's ways to implement this in every group to say, just opening the culture up of giving some feedback based on cases that you're seeing. And I think that's it, I believe. Yeah. Thank you.